Good evening, everyone, and welcome to the December 26th edition of Beyond the Data. Sorry, we're having a little bit of technical difficulties here, so if I cut out, I do apologize. I don't know what's up with it. And tonight we have Carrie Benton back with us to get our science on here, talking about testing, talking about the variants, talking about all that kind of sciencey stuff again, as opposed to the lawyers. So, before I get into it, I want to advertise again for this. If you do want to see a bunch of lawyers, which they are great lawyers, along with Dr. Lefay and myself, you can come and see all of us together in one place at one time on January 22nd with Ohio Stands Up. And if you go and get a dinner, you're also supporting a lot of the cases that they've been working on. I will also be having, hopefully, Dr. Lefay on for a special edition of Beyond the Data, probably Friday afternoon, early afternoonish, with more information on that to come. So, am I still steady at least?
Yeah.
Okay, good. It's acting like that it might be questionable here, so bear with me if it does happen. So we needed a Carrie day because Carrie likes to post things on Twitter that make me look at Twitter and stare at it for a while and go, what did I just see? Somebody explain it to me. It's going over my head. So, I mean, this is kind of an edition where we go, well, what is going on in Carrie's head? What is she talking about kind of edition. You've been putting interesting things out there, such as the monoclonal antibodies stuff. Do you want to talk about what's been happening with that one? That one I've been hearing from other corners as well.
So monoclonal antibodies, there's a difference between MAB, which is monoclonal antibodies, and PAB, which is your polyclonal antibodies. The FDA has actually authorized several different kinds, depending on what it is for. Now, there's two of the monoclonal that they do not feel will be effective against the new variant that is coming out, which would make sense because it was derived from the plasma antibodies, the convalescent plasma, before this variant was ever around. So that I can see like the theory on that, and that would make sense, and I totally understand that. And none of the antibodies work by themselves. Like no matter what treatment you get, if it's antibody, if it's whatever direction that you go, nothing standalone works. It needs to be in conjunction with something else. So those antibodies, be it MAB or PAB, that they're seeing work on corona or on COVID as a whole, they're the ones that are dual mixed. So it's not just one by itself standalone. So the two that they said we're going to hold off on those and releasing what we have, or we recommend that you don't use those if you suspect omicron. I just really I don't want to say that I disagree with that, but I don't know if we can sacrifice a treatment on a possibility of a variant, because that's still not the prevailing variant in our area.
Yeah, that was where I wanted to lead this into as well. I kind of jumped into it randomly.
Sorry.
But no, but exactly that, where I've had people who have told me the story of, they go to the hospital or they try to get monoclonal antibodies from their doctor or whatever, and they're being told, no, you can't have that because Omicron, except for, where is our understanding that particular person in front of you right there actually has Omicron? And you were kind of explaining some of this to me earlier as well about how are we coming up with our numbers on Omicron, and it's shady. I look at this and it's something something's not right here.
Yeah, I don't want to say that it's shady. Yeah, but typically, so you have a prevalence and then you have an incidence. and the prevalence is how many total cases you have, period, in an area at a specific timeline divided by the population. Whereas incident is the new cases on a specific timeline divided
Okay.
by the total population. Prevalence, we typically don't look at except for retrospectively, or if we are looking ahead to do a trajectory. But for right now, because that's not real time data typically, that's until COVID, we really haven't looked at prevalence as much as incidence. But here we are. So we are looking at it now. Um, there's also the issue of some MABs and PABs per EUA have to be given on an inpatient status, and some can only be given on an outpatient status. So if you're inpatient for whatever reason, but the one that would best fit your needs is an outpatient, because that's operating outside of the EUA, that patient is not going to get it. And vice versa. If there's no room at the end for you, but you have to be an inpatient to receive the MAB or the PAB that would best suit you, then you're not going to get it. So there's a whole lot of variables. It's not just something I need antibodies. Where do I go? I know I had to refer within the past week. I've referred 3 or 4, and I know that 2 for sure have went to different states. And the first time I did it, I called that particular state and said, before I go sending this patient there, what is your, do they have to be a resident of Tennessee? Because why would I send somebody from Ohio to Tennessee, where yes, they're easier to get, but at the same time, it's not going to help if it's for Tennessee residents only, and I'm sending somebody from Ohio. And they kind of like, do they have positive tests? Do they fit the criteria? Do they need them? Yeah. Okay. Have them call in for the screening, called in, and that was it. Patient was on the road. 10 hours later, I got that they had them, because they do have infusion clinics and that are set up where you don't need a doctor's order, whereas we do here. And it's almost like a drive-through. I don't have the answer for that, because I know even Florida is even easier than I just did Tennessee because it was the closest one that had a surplus. That of the one that I felt this patient would fit. We make it extremely difficult in the state of Ohio. But, if you look at it, different medications in general and different therapies in general vary from state to state. So the varying from state to state, that's not uncommon for anything. But the fact that it is, in my opinion, if there's a federal state of emergency, I don't care where you're from. I don't care where that you land. If you need it, we need to get it to you.
Well, and it's just, and what's most interesting to me, it's within the last week. I mean, this whole business of there have been previous times where people were saying they couldn't get it, they couldn't find it, kind of thing. Mm-hmm. Now I have people within the last week saying, I have been told straight up no, just because there's Omicron. Even though people right. who are following me understand it's there's no way to tell if it's Omicron right there, and then
right, and you can't, because that turnaround time is, even with the pilot programs that are in different states, the turnaround time for confirmation is still 3 to 4 weeks for that. So obviously you're outside of your window. But there's even monoclonal antibody that is the EUA specifically for exposure. It's a prophylactic for high risk individuals that fit the criteria of immunocompromise that we talked about earlier, um, Ohio just doesn't have it. It was never ordered. And that, so, that cohort of people that we're supposed to be protecting, if I recall correctly, at the very beginning, all of this was done to protect the most vulnerable. Let's not overtax the healthcare facilities and protect the most vulnerable. Protecting the most vulnerable needs to make sure that we have every tool in our toolbox that we can to help them. And Ohio just doesn't have that prophylactic, which is really sad because there's a lot of people that could benefit from that.
I mean, that kind of leads into this whole thing of this is Ohio's whole approach. The only answer is the vaccine, the vaccine, vaccine, vaccine. And then we were talking earlier about another thing that you'd been bringing up about the difference between booster doses and additional doses, and the fact that there's a fundamentally very large difference between the two in Ohio. Despite being obsessed with vaccinations, doesn't seem to know the difference and doesn't want to tell the CDC the difference, and is just a total mess. So if you want to educate all of us, since you were talking to lots of MDs who have no clue what the difference between additional and booster doses and why that's important. So if you want to tell us about that whole fun situation.
Yeah. So I guess I will take, for this area, some responsibility for that as well. I don't know what happened. I don't know where the breakdown is, but I assumed, and you know what they say about that the messaging was clear and concise between additional dose and booster dose. And then we started seeing billing issues where clearly the patient should have had an additional dose because the ICD-10 or the CPT code met it, meaning that they fit the immunocompromised criteria, and it was documented that they received Pfizer, for example, but their primary dose was then given with Moderna, or they consistently had the Moderna dose and they should have gotten the additional dose, but the Moderna additional dose was a booster dose because of the amount that was given. And so it was not like nothing was meshing. It shouldn't be happening. So at first you think, it was coded wrong. And so in speaking with multiple physicians and nurses, anybody that may code for that purpose, even pharmacists, it was, what's the difference between additional dose and booster dose? Not one of them had a definition that met the CDC. Typically, overall, a majority of them felt that those two words were interchangeable. And pre-COVID, they certainly were. But now they are not. And that can make the difference between somebody that isn't typically going to mount a response because of the medication they are on, and so they end up getting a fourth shot for no good reason. It's not doing much of anything. And somebody that gets the wrong dose at the wrong time thinking they're getting a booster, and then they have an adverse reaction like myocarditis, or something that turns on their immune system.
So to step back a couple things here. First of all,
okay.
I've gotten a few more viewers as well, and to know who Carrie is, you work in one of your capacities is you work as a COVID data trajectory analyst for the CDC. So that's where this information is coming from. Is that right?
Well, I'm independent provider. So
independent provider. Yes.
Yeah. The CD. So there's HHS, and then you have underneath HHS, you have CDC, you have FDA, and a couple other ones, but their employees that actually work for them are actually very few. Most of the individuals are independent providers, or what they call subcontractors.
And so that's when she's talking about the billing and stuff. She genuinely is seeing the billing and stuff. And to be more precise, specifically, if you could say what the difference between an additional dose is and a booster dose, because if the pharmacists don't know it, we don't know it either. And the state of Ohio lists it simply as the first additional dose.
Right. And I actually didn't know that that's what they did until speaking with you. So I'm going to share my screen. So that way that we can, maybe I might share it if I can. Technology's obviously not my.
You got this.
I hit the one that says share screen.
There you go.
Okay. Share screen. And then I want to share. Haha. There we go. Did I do it?
Yes, you did.
Okay.
Here it is.
So I'm just, can you see it or does it need to be?
If you can zoom in just a little bit, that's helpful.
Okay. Tell me when to stop.
That's good.
That's go.
It's good.
Okay. So we can get back to, I want to go down to the part that it actually tells you.
And this is from this is the CDC's webpage, the Labyrinth and CDC page.
Right. You can look right at the top and see it's cdc.gov/coronavirus, whatever's up there. I don't know what that you guys actually do, but let me scroll down. I just want to make sure that we are differentiating it well. So it's here. The difference between an additional dose and a booster dose is everybody is eligible for for a booster dose. And I don't know why it's not there. But the people that need to get an additional dose are those that are immunocompromised that meet a certain criteria. So for example, an additional dose would not, the individual that gets Johnson & Johnson, they would not be eligible for, there's nothing authorized at all for Johnson & Johnson additional dose, but there is obviously for the booster shot.
So the additional dose is specifically for people who do not mount an appropriate immune reaction because they have an immune response to the shots first two series or single series for the Johnson & Johnson. There's people who have those immune compromised conditions. And you showed me it was a very short list of people who have.
It's under here, who is severely immunocompromised. And this is it. If you've been receiving active cancer treatment for tumors and cancers of the blood, so it's extremely specific to cancers of the blood. If you received an organ transplant and you're taking medication to suppress the immune system, so typically your anti-rejection meds, stem cell transplant within the last 2 years, or if you're taking medication to suppress the immune system again, the moderate or primary immunodeficiency. So a primary immunodeficiency is genetic, whereas an acquired or secondary is something that happens because of something. So if you were receiving an organ transplant, then obviously that's secondary. Whereas these two syndromes that they discuss are a primary immunodeficiency. Obviously, at any time that we talk about vaccination, advanced or untreated HIV, and then active treatment with high-dose corticosteroids or other drugs that may suppress your immune response, such as your Plaquenil, which is HCQ.
Also known as HCQ.
Yep. Your Enbrel, Humira, methotrexate, all of those things. That's it. That's the only people that qualifies for an additional dose. Primary dose.
And the primary, so when we're talking about additional dose, we're talking about you've taken your first dose, you've taken your second dose, and then you're taking a third full dose
28 days later.
At 28 days later. So the booster doses are coming at like 6 months later. And then there's also the difference between the different vaccines themselves. Like Johnson & Johnson, you said you cannot have an additional dose.
No, but you can a booster.
But you can do a booster.
Right. Yeah. And this, I think, is extremely important because this is kind of how we kind of got those red flags going is no vaccine used for a primary shot. Or no, it says can you mix and match for the additional primary shot? No, you can't. If you are getting an additional primary, so you're getting it 28 days later after that second one, then no, you cannot mix and match. Now, if it's, I've never run into this situation where it's unknown. I've actually never run into a situation where it's not available. In that situation, they say, yeah, you can use either mRNA. They don't recommend it. I've never had that happen for a primary dose because, again, the dose, especially for Moderna, is different. So a booster is a different dosage than what you would get for an additional primary dose. Your additional primary dose is literally just that. Everything you got the first time.
And the second time.
And the second time.
The third time.
Just another one.
And pretty close in to the original.
Right. Doses. Yeah. So you're talking the difference between, 28 days and 6 months. Obviously, if you take an immunocompromised person and you give them that at 6, they think they're getting their third primary and they're actually getting a booster
specifically
amount.
And Moderna. Yeah.
Yeah. And that's specific to Moderna. Then, they're already not going to mount a response. And now you've just given them a half dose as opposed to the full dose that they need. And that can just cause them more issues or breakthrough than what's necessary. So it's really important as we see not only the individual advocate for themselves, but our providers definitely need to, and those giving those shots
need to definitely be knowing the difference. I mean, that's a critical difference. I mean,
it is
the time frame, the dosage, although it is kind of disturbing to me when you were talking about the fact that Moderna actually has a half dose for their booster, but Pfizer uses the exact same dosage every single dose, whether it's an additional, whether it's a booster, whether it's anything, and they just use that same dosing. And at the same time, we're not checking for antibodies. We're not doing titers at all. We have no idea if that person that we're giving a booster to, a full dose booster to, has super high antibodies. I mean, we just don't bother. We're just like, cool, let's do it again.
I'm going to scroll down real quick. So if somebody gets motion sick, please don't pay attention to what I'm doing.
Close your eyes.
Yeah. Here, what is the difference between primary and a booster? Additional primary is administered, as we said, to people that are moderately or severely compromised. The additional dose of the mRNA is specific to mRNA, whereas a booster shot is administered when a person has completed their vaccine series to enhance or restore protection that may have decreased. So, that wax and wane that we typically see when we do titers. But again, you could hold an immune response to it much better than I. And that goes for any type of vaccination. So, why are we seeing these people that are having reactions and then some aren't? Some say I did great. Well, did their protection wane? I don't know the answer to that at this time. I have theories just like everybody else. Here, I'm gonna stop sharing.
But yeah, I mean, it is this thing of you throw that on top of this pile as well of what exactly are we talking about? We're not even talking about the same things anymore, where additional dose is definitely different than a booster dose. A booster dose from Pfizer is definitely different than Moderna, and we've never bothered to actually check if anybody's got a titer. And it's just such an insane mess where in Ohio, where this is the only thing that has mattered, that to the point where we're removing any choice for any kind of treatment besides, well, it's too late. You should have gotten the vaccine plus a booster plus a booster plus a booster, because it's not working. It's failing left and right, and it's kind of obvious there. I mean, this whole business of what's been going on in the last week or so up in the Northeast Ohio area. I had put up a post just
crazy.
just last week. I put up a post because I have people who are harvesting the data every week for me, specifically the probables and confirms out of each of the counties. And one of them mentioned, well, Cuyahoga County is a huge number of cases. It is so huge. It makes up 1/4. Cuyahoga County, just Cleveland, Cuyahoga County makes up over 1/4 of the total cases over 14 days. So I had this graph here where these are the cases, and I chose a few representative type counties. Well, not really representative, but a few counties across the northern part of the state here over the last 14 days. And you can see the total number for Cuyahoga, which is in red, is just it just crushes everything else. Absolutely crushes everything else. The dark blue line is Franklin County, so Columbus. Now, and then I also have Summit County, which is where Akron is, Stark, which is where Canton is, so right next to Summit, and also Holmes, which you can barely see on here. Holmes County is, of course, where there's a heavy population of Amish, and they have, I think, around 17% vaccination rate right now. They're also really low on cases. So to make sure that there isn't any kind of argument against, well, oh, these are raw numbers and you can't compare Holmes County, which has, I think, around 45,000 people in it, versus Cuyahoga, which has like 1.2 million or something like that. So I put up a graph with cases per 100,000, a situation where this particular number actually is appropriate. And even then, you can see Cuyahoga County just crushes the rest. It's just out of control. And one of the things that I noticed when I was looking at this data as well is the counties that had this bizarre spike in cases were all right close to the lake here, where it's Summit County and Cuyahoga County were the worst, and then came Lorain, Medina, Lake counties also had some issues. I think Portage, maybe Geauga as well. They all had like a little bit. They had this weird hump and then the spike. But most interesting to me was Stark County. Now, Stark County is where Canton is. Summit County is where Akron is. And I grew up kind of in that area, and you say Akron, Canton in one breath. I mean, right. You just do. And why is it that we're seeing such a difference between Summit County cases and Stark County cases? I mean, the only thing I could come up with is to have such a massive quantity of these cases all in one little corner of the state just screams to me testing. Something about the testing situation that is true in Summit County, but not true in Stark County, and very, 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 very true in Cuyahoga County. So I'm thinking whoever's distributing these tests up here, that we're experiencing a nice testemic here.
And that makes complete sense, and what type of test, and are we using it within the EUA? There's just so much that's going on. Keep in mind that our tests, we don't have an approved one yet. All of our tests are still operating under EUA. There is no approved test. So we have an approved vaccination before an approved test, which I just find extremely ironic currently. But so we just have to make sure that those tests are being used appropriately. And that means that we have to ask questions, and we have to, sometimes look up the EUA. And sometimes that's just very tedious process when you just want to get in and get out, or, whatever the situation, or you just want to work. You just want to earn a living, to be able to feed your family. But before we go too much further, I just saw that Renee had a comment, that her neurologist told her Plaquenil is an immune modulator and doesn't suppress the immune system. The Plaquenil, which is HCQ, which is an anti-malarial drug, actually it's under the definition of a DMARD, which is a disease modifying. And what Plaquenil does is it blocks and suppresses the trained immune system. So it certainly decreases your immune response. Yeah, so I don't, neurologists are very smart, but they're not rheumatologists and immunologists either. So, every physician is going to approach it differently. So I don't know. I don't even know what that means, a immune modulator. Like no, it suppresses your immune system and that qualifies you for an additional dose if you so choose. I don't think so, but
I
just
don't
saying.
think you're going to go for it. No,
Yeah.
there are other reasons not to go for it.
Right. Yeah.
Yeah, so getting back to the testing, though, I mean, that it is an important thing because there are all of these tests being flung around and with
There's a lot.
incredible numbers on it. Where one of the ones I've seen in this region where I am, where the positive test results are through the roof, is Quick View from Cadell, which its percentages, its specificity and sensitivity are pretty epic here. I mean, the sensitivity is great. So here's the Cadell little insert type thing. It's a Quick View at home over-the-counter COVID-19 test. It allows consumers to easily perform the test themselves without a doctor's prescription and get the results in 10 minutes from a nasal swab samples. A Quick View at home COVID-19 test shows excellent performance, with positive results agreeing with PCR 83.5% of the time and negative results agreeing 99.2% of the time, delivering confidence to individuals running the test and helping to prevent asymptomatic virus spread. Now, Carrie here is laughing here because it's 99.2% sensitive. That means if you're getting a negative result, it's going to be very reliably negative.
Right.
But it's got an 8.
Except in Ohio.
What's that?
I said except in Ohio, because we do have that little disclaimer for our at-home tests that if that were to be negative, it does not exclude it. You have to look at the clinical presentation.
Yeah, we can get away with just having symptoms and a negative test, even a negative test that shows 99.2% sensitivity with a relatively, low prevalence. And even then, it doesn't matter. In Ohio, even if you have a very reliably negative test, it could still be COVID, because everything's COVID. But it has a specificity of 83.5%.
So that means that 83, because that's an antigen test. So 83.5.
And it's clearly very heavily tilted towards false positives and very few false negatives. It's a balance between the two. If you have high false positives, you'll have low false negatives, and vice versa. If you have low false positives, you're more likely to have higher false negatives. So they are heavy on the false positives.
Right. And so what they're saying is 83.5% of the time, that antigen test, when they reflex it to a PCR, because truly that's the way it's supposed to happen, except in Ohio, that it will agree with the PCR.
Which also doesn't mean that you are sick or infected or anything of the like. It could just simply be you have leftover virus in your mucus,
right.
And it doesn't mean
it's just a good point. Yeah, that's a very good point. As we know, that's why we stopped the test to discontinue isolation. As we know that you can go ahead and continue to be positive on testing for at least 90 days. Some people it's up to 90 days, but there's no viable virus that you're shedding. It's just so you're not infectious. But the exception to that rule is those that are immunocompromised and on immunosuppressants. They can actually shed virus longer, viable virus. So that's why we suggest that, it doesn't matter if it's their physician, it's just kind of a rule of thumb. And that's for anything that they're sick with, that 20 days is a good time for them to be isolated. One, to let their system come back up to where it needs to be, probably get back onto their medications that they had to stop during that illness, but also to make sure that they're not continuing to shed viable virus.
Specifically immune
Yes.
compromised people, other people who do not have, they're not taking medications to suppress their immune system and all those
No,
kinds of things. You don't need to you don't need to isolate anywhere remotely near that long. I believe
no, no,
5 days
that's
was
specifically
realistically.
for, yeah, no,
Yeah.
that's not. And actually, for healthcare workers, it's decreased. And then I believe tomorrow the airlines are going to decrease for their isolation time. And then we're going to see some more rollouts of who needs to, because, if somebody's decreasing, then they have to balance that with an increase on another cohort of people.
Yeah, I wonder
So
what those cohorts are going to be.
I can only imagine.
Yeah, I've been hearing lots of stuff about the nursing as well. That suddenly nurses who are vaccinated will no longer have to isolate, even if they have positive COVID tests, and even to mild symptoms, that's still okay. You can do that, but if you are unvaccinated, then you
Yeah,
still have to isolate for at least 10 days, et cetera, et cetera,
and
and
lose your job and all of
and
those things.
lose your job
Yeah,
and all
yeah.
of those.
That was they actually rolled that out, and it's on the CDC website on Christmas Eve. Merry Christmas
Yeah.
for and that to me, as soon as we start letting an industry modify or dictate public health, I have to question if it's really about health. And I'm just throwing that out there, but to me, if this is what the data shows, I'm sorry, this is what the data shows. This is what we have to do. It doesn't matter if you fly a plane or if you're a nurse. My concern is those positive nurses first. I believe that everyone in healthcare should have the ability to recover, just like you or I. They are still human if they are truly ill. But they are taking care of those that are already, for some reason, in the hospital. Even if they're compromised for a minute, something temporary, they had a joint replacement or they're, whatever, they're inpatient and they're ill. I just don't think it's in the best interest of the patient to have someone, I don't care if they're vaccinated or not, positive is positive, if they have symptoms or if they had symptoms. I don't feel that
Well, then
that
again, I mean, positive is positive when you're dealing with something like the Cadell Quick View one. Yes and no. I mean,
well,
it's
okay. If the procedure is followed correctly, which is an antigen test as reflex to a PCR.
that's true, right? With the PCR, then you can start maybe beginning to believe it, but even then, it becomes difficult because we do not know unless we know the cycle threshold that it goes positive as. Are you really? Are you or I mean, there's no question SARS-CoV-2 is out there right now in
Oh,
the air
absolutely.
we're breathing. If you have mucus in your nose and you breathe it in and you are immune because of natural immunity or whatever, or
Right.
just simply a good innate immune system, it's going to be hanging out in there. You're going to test
Right.
positive, but you're not infected. You're not sick. Maybe you do have a cold of some variety, which is creating the mucus that now those viruses are hanging out in. Are you sick from COVID? No.
Oh, I mean,
it's
no,
it's
I mean,
it's
and remember our tests, even though they're EUA, they test for SARS-CoV-2. COVID is the disease that's caused by the virus SARS-CoV-2. So let's just make sure that we're differentiating that as well, because no, you're not sick with COVID just from a positive test. COVID knocks you on your rear, for a day or so. SARS-CoV-2, you might not even know that you have it. I'm sure you and I have been exposed to several things over the course of years, and that doesn't, and we have some type of protection against it, but that doesn't mean that we became ill. I think it's 1 in 5 healthcare workers carry MRSA in their nasal passage. As long as it stays there, it's fine.
like
It's if
strep.
it's in a wound or something like that it starts to cause issues. Um, so that's just going to happen. And I think the other thing is, and this is where we're kind of getting tripped up, we've allowed every facility has been allowed and every manufacturer, because it's EUA and we don't have that 2 standard deviation policy in place because it's EUA, that some are running them at, 30, 40, whatever their CT is.
45.
But yeah, and under 28 or under is, obviously the lower that you go, but even to send the specimen to the CDC stat lab, it has to be 28 or under CT value. And I see a lot of people right now, and I always ask that same question. They say, so I know so and so, and they got COVID twice, or I got COVID twice. Like there's a lot of that all of a sudden that seems to be popping up. And I keep saying, where are they? Where are these people? Not that I don't believe you. I certainly do. I think that was said. But the criteria for reinfection per CDC is very, very stringent. And now reactivation, that's different. We're a little bit more liberal with that criteria, but the CDC criteria for reinfection is extremely tight. And one of the things is 28, the specimen has to be run at 28 CT or under in order to be sent to be sequenced for reinfection. I can tell you, and you can look it up to verify it, there are 50 known reinfections globally. Not one has ever come from Ohio, meaning it is mandatory reporting. The specimen must be sent to the CDC if they suspect a reinfection, and that has never, ever occurred from the state of Ohio. And I feel like there's a lot of people reinfected or saying they're reinfected.
Yes.
So are we assuming that it is? Is that just what they're calling because it's COVID-like? What was the time between specimens? Are we looking at a reactivation versus a reinfection? Where are these specimens? Because it's mandatory that provider sends them to the CDC stat lab. And Ohio hasn't done that.
It's crazy. I mean, the number of people who, oh yeah, I've gotten it again. I mean, again, this is where the extremely liberal definitions from Ohio really come back to bite, because they can call whatever they want COVID and it gets counted as COVID, and they're just cavalier about it. And just because you have cold symptoms does not mean that you were infected with SARS-CoV-2. And especially since most people are getting tested not most, but a huge number of people are being tested just with antigen tests.
Right.
And I mean, come on, 83.5% specificity, and we're talking pretty low prevalence even right now. I mean, yes, a lot of people are getting positive test results or cases, but we're still pretty low in terms of not prevalence, but incidence of it. A lot of those are going to be false just because that's how it works.
Yeah, so that somebody said, what is reactivation? They had never heard of that. And that's, you can look that definition up on the CDC as well. It's hidden. I don't know the exact pathway to get there on the public side. But reactivation would mean you had a positive test with symptoms, and within a 90-day period, you tested positive a second time.
With symptoms.
With symptoms for reactivation. And that's why we said, a year ago, they came out with a revision of you can test positive for up to 90 days. You don't need to test to end isolation because it might not be viable. But that is, once you get that symptoms component in, that's then a reactivation. So you felt like junk, then you felt better, then you felt like junk again within 90 days, and you tested positive both times. That is a reactivation, because it's not that it ever went away. And we see that happen with mono a lot. So it's not that it ever went away. It's just it came around again. Whereas a reinfection is beyond, still the same thing. Positive symptoms, a negative in between, and then a positive with symptoms beyond 90 days. And the specimen has to be 28 CT or under.
in the state of Ohio, Dr. Vanderhoff changed these rules. They took what you're saying right there, except for modified it. I'm sure, of course, because it's Ohio. For us, we just need any positive test or identification as a COVID case again, which of course can just be symptoms and who you are. That counts, and just an antigen test counts as being a brand new case. If you test positive and it's greater than 90 days afterwards, whether you have symptoms or not, that's considered a reinfection in the state of Ohio, and you get a brand new line in the CSV file, in the data file.
Right.
There's
So
no
that would
way to
be
tell.
right. That would be for Ohio. But if the provider truly suspected that reinfection, then he has a duty to report, he or she has a duty to report and send that specimen. So that specimen then has to go from wherever he is, he or she, to the state of Ohio. And the state of Ohio then sends them out marked for reinfection. And then from the state of Ohio, it goes to the CDC stat lab.
Yeah.
And then they genome sequence and variant ID it.
And I'm assuming they probably test for other pathogens as well.
Oh, yeah.
Because that's the important thing. I mean, we've known since the very, very beginning here that co-infections are an important part to understand. I remember one of the very first papers coming out on this whole business was about skiers in a Swiss chalet that included where there was an outbreak, and there was a boy among these skiers that also tested positive for SARS-CoV-2, and he had symptoms, but he was also co-infected with, I think, a strain of flu and a couple other viruses.
Yeah.
And they followed him. They were really concerned. This was really early. This was probably late February of 2020. And they were like, oh my goodness, this boy, he was in the school setting. It's kids are very infectious and they spread disease like crazy. And he was in 2 separate situations, had over 100 contacts. And they were like, oh, this is going to be terrible. And they found for the boy, none of his contacts also had the virus SARS-CoV-2, but he was sharing the other viruses. Very liberal. Everybody was sharing all the other viruses, but not that one.
I think I remember reading that a long time ago.
And we've forgotten it, because that's the important thing. Just because you have symptoms and the virus does not mean that the virus is causing the symptoms you're experiencing. That's what we saw in the fall as well, or late summer, early fall with RSV. We saw RSV was making kids sick, and they also tested positive, and so therefore were considered hospitalized or whatever
with a dual diagnosis.
In our data, in Ohio's data, there's no distinction between the two.
Oh, so see, on the HHS.gov,
they distinguish at least.
Yeah, you can look at RSV, flu, and then COVID, and then co-infection. So it splits it up pretty nice. Somebody asked, is losing taste and smell specific to COVID only? Dr. LaFay is not here, but I can tell you from personal experience that no, anything that causes an inflamed lining in your nasal cavity, in your sinuses, you can lose your taste and or smell. I mean, that stuff he knows. My kid just said last week they had a Big Mac and it tasted, I know, here we go, McDonald's. Well, guess what? I don't cook, I freaking work. But they had a Big Mac and it tasted like a pretzel, because she had all, she was all inflamed and stuff over there. And then somebody said, if they are doing at-home tests, a doctor isn't involved and isn't sending it for PCR and isn't getting genomic tested, then that's not a true reinfection, even though it may very well be. It doesn't count. It is what it is.
It's also probably pretty unlikely for it to be terribly much heavily reinfection, because that's not how immunity works. I mean, if you are immune compromised or you have some other issue that impacts your overall health, yes, and deteriorates your overall health, that's possible. But if you are, going along as normal, there's very little reason to ever suspect a reinfection with a virus like this.
Yeah, I just, not that you can't get a coronavirus. I mean, we get flus, but we get colds. Yeah, that all the time. But
not severe.
Right, and even the CDC publishes that the chance of reinfection is very, very low. Not that it does not exist.
Or the other thing that to keep again in mind here is reinfection is very, very low, but testing positive again is not that low, because
No,
testing positive does not mean infected. And
right,
they
and that was going to be my next thing. We got a lot of testing floating around, and I know that somebody had said earlier, it seems like that at-home test is a golden ticket currently. People that are looking for them. That couldn't be so more accurate. Like, I think I might steal that phrase moving forward, because and just because you have an at-home test, it doesn't mean that it has to be reported, by any means. Some people take it and they're like, oh, I'm positive, I'm going to stay home, and they toss them to the side. Other people run to the ER and say, I feel great, I was just working out, but I'm positive, so I'm here now. And that's where we run into issues with our ER. I'm by no means saying don't go to the ER. If you are sick, if you are short of breath, and you meet criteria, by all means. If you need to go to feel better, whatever about the situation, that's between you and your insurance and that ER. But
well, and also the ERs are getting overwhelmed because primary care physicians are not allowing people with symptoms into their office. And then you've got the hospital saying, don't come to the ER, go to your primary care physician. And it's like, guys, communicate for real. This is ridiculous.
But I just feel like as humans, at some point, we have to have some common sense. We have to have just a little bit of critical thinking. We are smart. Our species is not dumb. I think we're doing okay on the food chain. And we know better than some of this. I mean, I just think we've had such a huge amount of fear. I don't know another word for it, but when you hear something so much over and over, eventually you're like, man, this must be pretty serious. And it makes you afraid. And some people, that may be absolutely justified. But,
well, I mean, sorry.
Not for everyone.
Well, I mean, this just kind of leads into a post I made, I think it was today. Yes, it was today. About what is going on in our hospital system, specifically Region 2, which is Northeast Ohio. That's, again, Lorain, Cuyahoga, Geauga Lake, Ashtabula counties. This is Region 2 in Ohio in the hospital systems, according to the Ohio Hospital Association. And they put out there the major hospital systems about, I don't know, a couple weeks ago. They put out a statement talking about how their hospital systems are being overrun. They even took out like a full page ad. Cleveland Clinic took a full page ad saying, oh my goodness, our hospitals are exploding. Everybody get vaccinated this minute, even though if you did get vaccinated this minute, it's not going to help you right now. It'll help you at best a few weeks, a month or two down the road. So
are you talking about when they postponed?
Well, I'm getting there. They had that too, but this is
different. Okay, I missed that.
Yeah, this is the post. Well, this was this was last week. It hit, man. My phone was blowing up. That was for sure. With people who were like, whoa, what's going on here? Because they really ramped up the fear in this whole concept of our hospitals are exploding. We're completely overwhelmed. The COVID numbers are going through the roof and all that kind of stuff. But because I am capturing the data every day now since back into May, I've been able to follow along with their numbers. So here's the full data here from Region 2. Again, this is Ohio, Lorain, Cuyahoga, Geauga Lake, Ashtabula, just where the disaster is supposedly happening. And so this is the information from the coronavirus.ohio.gov website. And of course, you have to collect it daily because they like to make it disappear. And what you see on here are 5 different lines that show different occupancy. At the bottom, very bottom, is the COVID occupancy. And you can see it bumped up in fall, and then it went down again, and then it really went up a lot higher in the last couple months here. Above that, we have our available beds, which there have been more available beds this entire time than there have been COVID occupied ones, even right now. And then you have another line that's showing above that the non-COVID occupancy. These are beds that are occupied by people who are not being identified as COVID. Now, the fun part is you can see, I have it at a different one, a different graph showing that it mirrors the COVID hospitalization. As it increases, the non-COVID hospitalizations decrease. So because all of a sudden there are more COVID hospitalizations, there are fewer heart attacks happening, fewer accidents, fewer anything else. I mean, that's what this data is showing here. I mean, that's nonsense. Instead, what we see is the top yellow line, which is showing, you see the up and down, and those up and downs are each representing a week. Weekends are lower occupancy, weekdays are higher occupancy. And we see it just goes pretty much straight across. When you add the COVID occupancy to the non-COVID occupancy, it's pretty much flat. It's not changed at all. And the best part is I pulled from the statement that was a joint statement between Cleveland Clinic, University Hospitals, and Metro Health, which are the major hospital systems in this region. They had this beautiful statement saying the COVID-19 pandemic continues to challenge healthcare providers globally and nationally, including Cleveland Clinic, the Metro Health System, and university hospitals, resulting in yet another surge in the number of COVID-19 patients. As we continue to navigate the pandemic and adjust to the changing healthcare needs of our patients, our health systems are seeing unprecedented demand for inpatient care across our facilities. And if you look at the yellow line, which shows total occupancy from May all the way through Christmas, it's flat. There's nothing unprecedented about this at all. It's consistent. Same number of beds are being occupied. COVID, not COVID, it doesn't matter. And this just, I mean, it's so frustrating. They're just manipulating our feelings. They're saying, oh, it's unprecedented in the number of people. No, they're clearly just testing positive. And they're there for another reason. Because you don't.
Yeah, that makes my eye twitch. Like, we can't talk too much about that because it drives me insane.
Mm-hmm. But that's what they're doing. They're pushing this massive amount of fear. Oh, we're having exploding COVID. Well, how many people, especially up here in Northeast Ohio, know lots of people testing positive right now with no symptoms or mild cold symptoms? And what is being tested right now? Because something's funky up here. Like I said at the beginning, 25% of the cases in Ohio were in Cuyahoga alone.
And I mean, it's a very, the more you test, obviously, but the more you're going to find. I mean, if you're going to find what you're looking for.
Especially when you're using tests that are 83.5% specific.
Right. And then, are you collecting the specimen correctly? Are you reading the specimen? I have a whole bunch of questions with that. But even beyond that is, we ourselves as people, as well as kids, we depend on kids to go to school or to be out and about and to eat dirt and do those things, to bring that back to us. So we're exposed to it a little bit at a time. Kids are going to be kids. It's going to happen. And they're going to get sick.
And that's
we depend on that to bring it back to us. So as adults, we are exposed over time, a little bit at a time. Well, for the last, 2 years, we've had them in masks. We've had them at home. We've had them isolated. And then they were pushed back out into the world again in August. And all of a sudden, boom, we saw RSV in August of all times, when that just doesn't happen. There is a level of immunity debt, and we are still going to continue to see that level of immunity debt. I have one right now, and by golly, she's walking out. And that is the perfect example of immunity debt. There you go. There she is. There it is. I promise she does not have COVID, you know. But yeah, so but that just, you know, we're going to see those things right now. We did this to ourselves by allowing this to continue to happen and stay like that. And even though you or I didn't modify our life as much, those around us that we would typically come in contact with, even at the store, you know, did.
Yep.
So that just happens. I feel like I'm gonna get children's services or something called on me for my adult. She's an adult child who is hacking and coughing. I swear she's sorry.
You should give her one of the quick views, and then she can be counted again in the system.
She would probably lose her mind. That's not the one to do that to. So.
Not the test. Speaking of which, one last thing I think we should talk about tonight as well is another one that you popped up there on Twitter that just made me nothing to see here about some of these new tests that are going to come online. Part of the 500 million tests going to be sent to us.
Oh, that one. I thought you were talking about. Yeah, I thought you were talking about the Cleveland Clinic self.
Oh, well, we can do that. Yeah, let's do the self one. Yeah, I've got those.
So, and this actually might be helpful for somebody that is looking for. You know, there's college kids that are required to have a test to go back onto campus. Like, you can't change it. It is what it is, you know, right now. But these parents are going, where do we get these? Like, where are they right now? We can't find them.
And which ones should we be doing? Should we use Quick View?
No. I mean, it's like a brand of clothing. Like, I don't really care, but I have my favorites, and my favorites might not be yours. I would not recommend. You have a lot better options. Let's put it that way. There's a lot more better options. But so my son became ill, and of course I have Coffee McCofferson that you guys just heard walk through, and but there's a definite difference between a post-nasal coughing something up and a deep sputum coming from the lung coughing something up. And he was wheezing, and he hasn't done that in forever. And you know, we have Chip in the home, and I truly, because it was coming so deep, I was not thinking COVID in any way, shape, or form. I wanted him to have a chest x-ray. I was truly concerned. I know when I was in college, and maybe it's changed, but if you're coughing up yellow or green, or blowing out yellow or green, or if there is any yellow green coming from your orifice on any body part, then, you know, coming out of you in some way, that's an infection, and it needs to be treated.
Real infection.
Right. However, because of his symptoms, he could not go into the doctor without a negative test. And I said, I don't care if we come see you or not. I just need the chest x-ray. I understand that you don't want to listen to me, even though I'm telling you I hear bubbles in his lungs on a stethoscope. And, you know, I would feel much better if he had a chest x-ray. He's yellow and green. The response was, well, if it's COVID, he will bring up phlegm. I said, not yellow or green unless it's advanced way too far. So I said, fine. You can't have the antibiotic, even though there's yellow and green. No antibiotic prescribed until there has a chest x-ray, but the chest x-ray can't be done until we know it's not COVID, because, he might make somebody sick in a doctor's office, and they are trying to keep it clean. So we had to go, and here was the next issue. We can schedule you for a COVID test where you drive through at the Cleveland Clinic, but they were booked out until next Wednesday. So that's not the Wednesday we just had. That's like in the three days. That was, and I'm like, our window is done by that point. and he needs an antibiotic. Like, he has an infection. I can tell you he has an infection. So the other option was this handy dandy new thing they have. It's called a self-check COVID-19 swabbing kit. Now, I live in a very rural area, so to go to the nearest Cleveland clinic, it is 40 minutes away. So I had to drive out there, walk in, and say, I am here to pick up a self-check test. And they handed it to me, and then you get these instructions with it, and I just like couldn't even believe it. I had to walk out to the car with him there, swab him, follow the instructions that are on this piece of paper, and then you put it into like a mail. It looks like a FedEx box. You put the kit, self-check kit into, and then it comes back in 24 to 48 hours. So he comes back negative. No kidding. So can I please get the, okay, great. Can we go ahead and order that chest x-ray? And we would love to, but there is no staff for the outpatient radiology. So we're just going to go ahead and call you in an antibiotic. Okay. Which is what I asked to begin with.
I mean, what's most infuriating about this is they are actually causing far more damage. It's right. Mind-blowing. I mean, these again are, and this happened to your daughter as well, where they would
right. And so, but with hers, I totally understood. It was I didn't understand, don't get me wrong, but it was a provider that was not her doctor at all. Her doctor was on vacation, which has since retired since then. And at that time, they only wanted the antigen test. And I said, no, if we're going to do this, we're going to do it right. We're going to exclude, and we're going to do an antigen test and a PCR, which I did end up getting billed for, whatever. It was fine. It was point proven. And she didn't have either. She had strep and sinus infection and ear infection. Like, she was very, very sick, and it took 5 days. I finally told my son, I said, I understand that you like your primary care. It's great. I can't do that again. Like, I can't deal with that. Whereas my daughter's provider that she has now, she said, look, we can do this every 6 to 8 weeks, because she literally gets sinus stuff every 6 to 8 weeks. She's old enough to say, I'm getting an ear infection. You can look at her throat and you can say, oh, look, there's pieces of bread, it looks like, on her throat. It's strep, and strep has a distinct strep.
Well, yeah.
Yeah. And I said, we can continue to test her every 6 to 8 weeks, but it is what it is, just treat it. She has a history of it. So I haven't had an issue since, but it literally took going on from here to down to the state house to say, this is not right. Here's my receipts of what I paid. And I followed her through. She is a confirmed case on the dashboard, tested negative, and had strep and an ear infection and a sinus infection. That is not right. That skews the data.
And as we could see, I mean, her case is clearly not unique. I mean, we're seeing so many of these hospitalizations. I mean, I would argue the vast majority of these hospitalizations are not COVID, right? Because it doesn't make any sense at all to have a lowering in other. That's not what happens in flu season. In flu season, we see, total occupancy go up. Not now. I mean, we're watching non-COVID drop like a rock, and we're watching, there might be some commentary here about, hey, well, that's because they've reduced their elective surgeries. Well, I pointed out on this graph here, way over on the bottom right here, right before it really dropped off a cliff, where it was that they started, limiting their elective procedures coming in again. And you can see that it paralleled before that. It was already dropping before that, because these people the majority of them are not or whatever it is, they're not there for COVID, at least initially.
Right. And right. And I mean, they can acquire it nosocomially. There's nothing that says that they can't. And I do believe that's probably happening quite a
Absolutely.
bit. And we're going to see an increase in that, especially if we allow our healthcare workers to go back. If they were truly sick with COVID,
Mm-hmm.
we allow them to go back,
Yep.
then we're going to see an increase in nosocomial infection. It's going to happen. Like, we need to be prepared and expect it. But it definitely is concerning for, we've had Erica's surgery canceled for, I don't know how many weeks now. I lost track, but they're not even looking at it again until January 10th. And we were given the option of, opioid and narcotic pain meds, or to implant, a pain pump. And during that time, but she's like, no, why would I do that? I've dealt with it this long. And not to mention that it's not going to help post-op, like, if I'm already at that level, she doesn't want to be in that situation. And she's really weird when it comes to taking meds. Probably if she would take meds, that, she just is very strange about it. And that's a personal choice, and I respect it for her. But, with my son, we ended up with a cough syrup with codeine, and I'm very glad that they did that in the meantime. And an inhaler that he hasn't used in years, and a steroid. And then I'm like, yeah, until you treat the infection, like, you're
Doesn't
just
help.
masking it. So it was a little bit frustrating. I promised that I said both all members of the family would get one freebie where we followed the rules, as if, we were like your normal everyday folk. But then that one freebie was all that was happening. And my family has exhausted their one freebie so it will not happen again. But luckily, he doesn't really get sick, so he doesn't sound like cough McStuffins back there. So, and with that cough, I mean, I truly don't even know if they will even touch her for
Yeah.
surgery. And that's a normal cough for her. But can you imagine going out to the store right now with that? Like, they want to drop a Lysol bomb on you, and, leprosy. I mean, she's like, I don't even want to go anywhere. Not just because of that, just because of hearing that and the way that people are. So she's like, I'll just stay home. So,
And then, of course, if we want to finish out, would you like to finish out with your eye health story?
oh,
On a, I don't know if it's a laugh or a cry or a,
I think it's funny because, I mean, why not? I don't know. Do you have the stuff?
oh, of course I've got the stuff. You
Okay.
know I've got the stuff.
Oh, actually, after that, I'll go through it quick, but then can we pull up that one part about the RPR that you have at the bottom for the very last thing?
Which one am I pulling up now? I don't remember.
Go ahead and pull up the eye health stuff, but the link I sent you right before we went on.
In Messenger, yes. I can do that. Here, let me pull this up here first. Let's see here. Who are you? There we go.
Okay.
Thanks, Carrie.
So our eye health that we should all be getting in the mail are our at-home tests that they're going to be sending.
The 500 million, or at least part of the 500 million.
Correct. And this just goes to tell you what, Eye Health Lab is a subsidiary of Andon Lab, which is a Chinese home health product. Yes. And Eye Health is a venture with its parent company, Andon, as a venture with another lab. So there's two ventures. You got Andon, and then you have the Mologistics, I think it's called. Starts with an M. It's Mologistics. But anyway, so you have
Mologic.
Okay, Mologic. I wasn't sure. Yeah. Sorry. So you got Mologic and you have Andon. Mologic, the ventures together is called GAH. So the CEO, CEO president of Mologic that also developed the test. I don't know if anybody knows what GAH is, but that is co-owned.
Do you want me to pop up your
Yeah,
next
go
one?
ahead.
Here's the Global Access Health, GAH, the
So they purchased
Soros
Mologic.
Economic Development Fund and the Bill and Melinda Gates Foundation announced the launch of a new initiative, Global Access Health, GAH, aiming to strengthen the global rollout, saving medical technology, and the subsequent acquisition of Mologic Limited, best known today for the deep nostril technology used to deliver rapid COVID-19 tests. The technology can also be used to test for dengue, bilharzia, and river blindness. So this sounds fantastic. I mean,
It
we've
is.
got
So
Soros,
everybody,
Gates, and a Chinese company.
yes, and everything is stored in the cloud on iHealth because it doesn't have to just be a test. It can be, there's all kinds of things. But the ironic thing is, several people are like, oh, after December 31st, we're not going to be using the PCR, and I have to go through that. No, that is one test that was developed by the CDC. And that was a notice that went out to the lab saying, if you have been getting our test for free, we will no longer be sending them, because it's at the time to where they either have to sell it or shelf it. So they sold it. And when they sold it to a particular company, they sold it to the Andon. So it was rebranded as iHealth.
So the Andon is okay. So for those trying to follow here, you have the CDC test, the original CDC test that the CDC developed and was giving out to labs for free. For up until December 31st, it's still being given out for free, and we've all probably seen at this point that document some months back where it got conflated with a different test that really was being pulled back. That the CDC was backing away from the PCR test. No. CDC is not backing away from that technology. What they're doing is they're saying we're not going to make this for free anymore.
Right. They can't. At some point they have to, whatever specified, they either have to shelf it, which means it's like orphaned, or it has to be sold. Those are your two tests. They sold it.
Andon, which is making iHealth, which is a big part of the antigen tests that are coming to a home near you, which is also in a nice little grouping with the global, what is it, Alliance for Health or whatever it was, which is a nice little grouping and coming together of the Soros Foundation and the Bill and Melinda Gates Foundation. So we've got Soros, Bill and Melinda Gates, Chinese company that bought the CDC PCR test and is now sending tests to our home.
Right. So PCR has been around long before COVID-19. Long time ago. But the CDC came up with their own test, which was actually designed by an individual called Dr. Fang. And he's also the CEO of iHealth. So, that's how it all ties in together. So it's basically the same test. So if I develop something and I sell it, and it gets rebranded, I still did it. I made that. I invented it. That particular reagent, that test, whatever it is, that pair of shoes. But I sold it. That doesn't mean that it's going away. I mean, it's rebranded. It's got a new name on it.
Yep. And in this case, it's Andon that bought it. And we haven't heard what's going to happen to the CDC PCR test. I mean, I'm assuming they're going to put it out there and start selling it. And I wouldn't be surprised if they go for full approval because it was a CDC test.
The CDC can't. So
CDC can't. What I'm saying is Andon. I wouldn't be surprised.
Oh, yeah. I look for them. I look for iHealth, absolutely, or Mologic.
So they'll have the first.
Right. Just like, Binax now is by Abbott, or your shot it's a joint venture. It's Pfizer and BioNTech. this is the same thing. It's a joint venture, and that's how it goes. And then, however, I guess I don't know, but they're going to come to your house is the tests are going to. What happens from there, I have no idea. I don't know, but that's just how that
That's
goes.
who it is. And but this isn't all of the 500 million tests, as far as I understand. They're going to have to contract with some of the other companies, but I mean, this is one of the big players in it. Uh-oh. You're telling me all 500 million are coming from iHealth? Oh gosh.
I mean, I don't know that they have that many. I wouldn't be shocked because the only places that it's been going is labs. Like, these haven't been out to you or I, it's just been labs, and it's been labs, and most labs did develop their own. Like CCF has their own. If you look on the bottom of that paper that looks like this, it says this product has not been FDA cleared or approved, but it has been authorized for emergency use by FDA under the EUA. And if you look on the FDA site under the EUI, it's every single test that's been authorized. I don't know of a hospital at this stage in the game that doesn't have their own. So that they're running, maybe in their outpatient labs, yeah, they're running whatever, but in their, lab, that their main lab, it's not a point of care test. Most of them have their own. So
yes, they bought Mologic.
Right, yeah.
Which is all involved up in here. This is a very nasty little group of people.
It's like what did you call it? 6 degree.
We're not even 6 degrees. We're like 1 degree of separation. We don't even go to 6 degrees
and,
in this.
And I mean, maybe world. It's a really good test. I don't know. I mean, I can tell you, I have not used it ever. Maybe it's perfect. Maybe it operates within the 2 standard deviations. Any test is a device. So they have a whole different criteria than what a vaccine or a therapeutic does. There's not a whole lot of, like I explained to you before. So whatever test, which I can tell you was the CDC test, every test was developed from some type of test that was already authorized. So even if I develop a device and the one that I developed it to be in comparative to has been discontinued for whatever reason because it didn't perform up to standards, maybe, that doesn't matter for mine. So a lot of tests, devices are totally different from the FDA. And, the FDA, there's a huge documentary that is very accurate. And they say that, it's an imperfect system when it comes to devices. But I know it's getting late, so we'll probably wrap up if you don't have anything except for the shots. The very last thing for those that are getting the shot, there is now a notice to providers that are giving it. I don't know if you have it or not.
Which one? Oh, let me, I think I have the last thing that you sent me in the message.
Yes. Yep. Yes. It's at the very top in a box. It's fantastic. If you can't get it, that's fine.
Or I can get it. Okay. I have ways. All right. Just give me a moment to get it there. It's just a different window. I believe this is it. This is what you wanted?
That is. So if you scroll down.
Woo. Scroll down?
Yeah.
To this box?
Oh, yep, right there. So it would be the third bullet point down. Update to alert providers of a possible false positive RPR, or rapid plasma region, for the test results in some people after COVID-19 vaccines. I would like to, for anybody that, watches Catherine, because I'm not around much, but I think I would like to challenge everybody to look up an RPR, rapid plasma region, and see what that test is. And then why do you think a false positive would occur in that test after a vaccine that may or may not have anything to do with it? So what would trigger that response? So this is critical thinking, and I think that you don't have to have any medical background to read, and I think it's pretty straightforward. I want to see what Renee Hedges always has, like these fantastic things. Like, where did you come up with that? So I can't wait to see her answer for that.
This is a test, Renee. So there you go. Next time Carrie comes on, we'll have to remember to have the answer to this question. What does this mean that you're getting a positive test result on a rapid plasma reagent?
Yeah, I truly don't know. That's why, I don't think anybody knows right now. Maybe not. I think there's a lot of theories. So I'd like to see what the general, like, because I'm obviously socially awkward. So maybe my brain doesn't work like most people. So I'd like to see, like, is my brain right or is my brain wrong? I learned just as much from this as what anybody else does.
Well, thank you for coming on again, Carrie.
Yeah,
it's always my brain goes a little splat. And I need you to explain yourself when you just drop these little nuggets all over the ground, and I'm just left going, what? Especially when you like send me 55-page documents and you say simply, do you see it? No, I do not.
Yeah, I probably do that.
You do that. Not a probably. You do this to me, and no, Carrie.
But I also send things like save this until I can get it on a jump drive because.
Yeah, those too.
Right.
Right.
I need it for something. I just don't know what it is right now. And we are just absolutely slammed between the trial and between, like, I think it's like 18 hours a day. So doing this, I just finally said I'm not doing anything the day after Christmas, as far as that. That's why I look homeless, but it's fine. The animals don't care when I fed them. So making their saws, they could care less. So.
And on that note, thank you, Carrie.
Have a good one.
And thank you, everyone, for coming and listening.